All right, we're going to start. I don't know if I really need this mic, but I have to talk into it for the virtual, I think. Um, so hi, everyone. Thank you for coming. You are at the CNO and SAPHO SIG session. Make sure you're in the right room. I'm Melissa. I am the fellow for the CNO working group. I'm going to start us off with just kind of an overview of what we're going to do today, and then we will get going. So first, we're going to go around. We're going to do some introductions, get to know everybody. Then we'll hear from our wonderful patient/parent research partner who will give just a brief talk about whatever he'd like. And then we're just going to kind of review a little bit about CNO and SAPHO for people who may or may not be too familiar with the disease, just a quick brief overview. And then I'll go through our what we've done so far to catch people up, because I know there's new faces in here. And then we'll do our breakout group, and I'll introduce all of that when we get to it. And then we will wrap up. So first, let me introduce two of our co-leaders who are here today, Christian Hendrick and Philip Meath, and they will start the introduction.
Thanks very much, Melissa. So I'm Christian. I'm a pediatric rheumatologist and currently working in Liverpool. And I'm spending my life on trying to figure out chronic non-bacterial osteomyelitis. So chronic non-bacterial osteomyelitis, or CNO, is what we call an autoinflammatory bone disease. And as such, it's defined by organ-specific or systemic inflammation. So organ-specific, it does at least affect the bone. In the absence of high-titer autoantibodies and a dysregulation that at least initially does affect the innate immune system, so not the adaptive immune system. However, that probably can change over time, and I'll talk about that in a second for a bit. While it can generally affect all age groups, it's really, really rare in children younger than 3 years. And in those cases, especially infectious causes or other autoinflammatory diseases with bone inflammation need to be considered. And it's less common in adults as compared to children. And the peak onset of this disease ranges anywhere between 7 and 12 years. So, it does cover a relatively broad clinical spectrum. We sometimes see patients with relatively mild monofocal and monophasic presentations, but much more frequently we see patients with multiple bone lesions that are chronically active or chronic recurrent. And in those patients, we talk about CRMO as well. And as you can see on the right, CRMO usually affects long bones in a symmetric pattern, but it can also affect the vertebral spine, where it can result in compression fractures and quite bad complications. I did say that monofocal and monophasic disease can be mild. It doesn't have to be mild. Some patients with a single lesion affecting the clavicle or the mandible or an individual vertebral body can have significant pain or fractures even. There are associations with other inflammatory diseases, especially palmoplantar pustulosis and psoriasis, acne, and inflammatory bowel disease, and it affects both colitis, ulcerative colitis, and Crohn's disease. In the adult age group, we see a symptom complex referred to as SAPHO syndrome, and it stands for synovitis, acne, pustulosis, hyperostosis, and osteitis. And we think that this may be very closely related to pediatric CNO, or even be the same condition with a slightly more aggressive and colorful clinical pictures in adults when compared to children. And we do believe that because all those individual symptoms can be present in pediatric CNO patients, however, less frequently as compared to the adult cohort and less commonly in combination. So as a disclaimer, we pediatricians have much more experience with CNO limited to the bone than with SAPHO. I think I've seen 2 or 3 patients in my career. So about 15 years ago, we didn't know very much about the pathophysiology of CNO. The only thing we did know is that it's associated with those inflammatory conditions that are all already named. And there was one study from France in which colleagues reported that patients who had only been treated while being symptomatic with non-steroidal anti-inflammatory drugs in adulthood quite frequently develop disease that's very similar to ankylosing spondylitis. And for all of those conditions, a significant imbalance in the expression of pro and anti-inflammatory cytokines and resulting inflammation is a hallmark. So this is what we think to know about the molecular pathophysiology of CNO nowadays. So we do know about that pronounced imbalance between pro and anti-inflammatory cytokines expressed by innate immune cells, namely monocytes and macrophages. And that results in too much pro-inflammatory cytokines, including IL-1, TNF-alpha, and IL-6, and not enough of the immune regulatory cytokine IL-10 that could control inflammation. And what we know is that this contributes to increased osteoclast activation and bone inflammation and inflammatory bone loss that can also result in fractures. We did talk briefly about SAPHO syndrome, and not much is known about the pathophysiology of SAPHO, but we have hypotheses. So that imbalance between pro and anti-inflammatory cytokines can contribute to an activation of the adaptive immune system and the differentiation of effector T cells, particularly such T cells that can produce IL-17. And IL-17 is a very key cytokine, for example, in psoriasis and also palmoplantar pustulosis, so conditions that are part of the picture of SAPHO. So therefore, we think that nowadays, with different biological treatments, we could offer individualized treatment moving forward. And Melissa is going to talk much more about the treatment. So currently, we don't have any licensed treatments for CNO. And the reason for that is that there are no clinical trials that would allow us to get approval from regulatory agencies. What we currently do have, and Melissa will talk about that, are consensus treatment plans that were led by Kara and Dan Zhao, with European partners being very closely involved. And as a result, we are collecting patients in the QUIRE register to get some evidence out of day-to-day patient treatment. One of the big concerns why clinical trials are not done currently is that we don't have outcome measures. So therefore, this OMERACT exercise is really, really important for us as a group. And with this, I'll hand on to Philip.
Thank you and welcome. My name is Philip Meese. I'm a rheumatologist, adult rheumatologist from Seattle. So you might be curious why an adult rheumatologist is in a bar like this. And it's because some years ago, I was approached by Dan Zhao, who's a pediatric rheumatologist based in Seattle. And he was finding that a lot of his patients with CNO were growing up and becoming adults and still having painful lesions and still needing to be on TNF therapy or pamidronate or experimenting with newer therapies like IL-17 inhibitors. So I agreed to see people that were graduating from the program at Children's Hospital in Seattle, and then started seeing people that were flying in from other cities just to get some verification on their ongoing therapy, as well as collecting data and contributing to the ongoing registry database that's being collected. I'll also mention that we have on this call in this meeting virtually a person named Philip Hellawell, another Philip, who is from Leeds, UK. And he happens to have a real expertise in SAPHO. So it is contributing, but it's now 7 minutes after 1 a.m. In England. And so we're going to try to get his involvement and then let him go to bed. So the other co-chairs are Christian Hedrick, who you just heard from, and then Jonathan Akuza. We have someone named Melissa Oliver, who's theoretically our fellow, but she's really a super fellow because she's leading the whole group. So it's sort of odd to think of you in that role. We're going to hear more from her shortly. And we also have in the room Alex Theos, who is a very dedicated parent to a child with CNO. And what we've been finding in the focus groups, for example, is that the involved parents have a very meaningful role in advocating for their children and being very interested in the disease. And then Bev Shea is our methodologist, who has been attending all of our meetings dutifully and helping very much with some of the OMERACTian cult type of activities that the group has been doing. And then this is the whole working group. And there's Philip in the lower right-hand corner. And then others that are coming in from really, this is quite a large international project. So what we'll want is to get a sense of everyone who's here today, and answering these questions when we separate into a couple of tables to talk about where we're going from here. Well, we've already got a piece of paper going around. Oh, you mean asking people? Your choice in that regard, Melissa. So,
so I'll start in the back because we introduced the front already. But yes, if you could, yeah, briefly just tell us name, role, country, how long it took you to travel here, and how familiar you are. Like somewhat, very somewhat, or not.
My name is Max Mischkowitz. I'm coming from Berlin, Germany, and there I am on my way to becoming a pediatric rheumatologist. And it took me the flight took me 10 hours, but yeah, I had to travel in Germany, so it's a little more than that, but it was manageable. And I think I've seen 2 patients at max with these conditions. I read up about it, so I'm familiar somewhat at best.
Alessandro Consolaro from Genova, Italy. I am a pediatric rheumatologist. Well, it took 15 hours to get here, more or less. How familiar? We have quite a few patients at the Gaslini Institute with CNO. I would say some few dozens. And very, very important work.
I'm Beth Gottlieb. I'm a pediatric rheumatologist in New York, and it took me far less time to get here, so maybe 5 hours or something because of a stop. And we have quite a number of patients with CNO that we care for in our division.
Great. I'm Erin Belay-Dustard. I'm a pediatric rheumatology fellow at Seattle. So we, I think Essie was here, but we have quite a Seattle conglomerate. Let's see where I'm from the US. I'm from Seattle. It took me 4 hours to get here, so the numbers are decreasing around the table. I follow several patients with CNO of varying degrees, so that has been, I mean, I work with Dan, which is a blessing always, so I get to learn lots from him. I'm moderately still.
You're at the, the epic center of CNO, so you'll see more.
Hello, my name is Mikkel Østergaard. I'm a adult rheumatologist from Copenhagen in Denmark, and we don't see these patients generally, for sure. So I don't know much about it.
No problem. That's why we do a review. Thank you for joining.
Hi, I'm Alfita Sabrin from Birmingham. I'm an adult rheumatologist with special interest in imaging, in particular ultrasound. It took me 18 hours to get here. I wrote 1 case report, I think, that we did not submit in the end, and I vaguely know the patient. So that's my. But I'm here today. Quite like to see the thought process of how you exclude the multiple domains you've got.
We will definitely delve into that.
I'm Walter Maximovich. I'm an adult rheumatologist in Edmonton, Canada, University of Alberta. It took me, about 2.5 hours to get here. And main reason I'm here is because in addition to being a rheumatologist and on faculty, I have an academic research organization called Care Arthritis. And we've been working with Dan and others to develop a web-based scoring interface for the MRI lesions. And I gather that's coming along fairly well. So ready for prime time, perhaps. But I'm certainly interested, and occasionally we do see these patients, and it's in the differential diagnosis of certain unusual types of spondyloarthritis, and psoriatic spondyloarthritis.
Great, thank you. I'm going to skip Christian and Philip, although I will say Christian might have traveled the longest to get here. What was it, over 60 hours? I mean, not 60, sorry. 29 hours. Okay.
My name's Kara Corpse. I'm a PRP here. I'm from Ohio in the United States. It only took me about 3 hours to get here. I have zero familiarity with CNO, but I'm also a veterinary pathologist, and we do have young animal autoimmune osteomyelitis entities, so I'm very curious about the overlap.
Well, I'm Marinka Schultz. I'm also a pediatric rheumatologist and part of the CNO group.
How long did it take you to get here?
Only 2.5 hours from Phil.
All right, and without further ado, here's Alex Dios. Feel free to say your role and how long it took you to get here as well too, and how familiar you are.
Sure, yeah. No, my name's Alex Dios, and as Melissa said, I'm in one of the PRPs in the CNO OMRAC group. I'm the father of a currently 14-year-old. My son Chris was diagnosed when he was 7 with the chronic recurrent multifocal osteomyelitis kind of subtype of CNO. So because I was just kick into the patient partner perspective. This is my first OMRAC, and I'm suffering a little bit from, despite the fact that it only took me about 4 hours to get here from Washington, DC, suffering a little bit. So I wrote down my comments so that I would deliver the information that I really wanted to share with you guys. So this OMRAC project is one that is very, very close to my heart. As a parent of a child diagnosed with CNO, CRMO, this disease is quite hard. For example, it's incredibly hard to learn as a parent how few patients your child's physician has actually seen, cared for, or how relatively little is known about how one patient responds to one type of therapeutic intervention or another, or how empirical decisions regarding treatments are. How long will this disease last? How do we decide to continue or discontinue medications? When there's a chance that your child's debilitating pain will just come roaring back. The long delay in diagnosis is stressful and concerning as that is then followed by lots and lots and lots of questions with few, if any, of the answers based on any kind of evidence. So fast forward to where we are here today, there's a desperately urgent need for more and more of the kind of evidence that will allow health systems, for example, around the world to provide much needed existing therapeutics, none of which are approved for use for CRMO, CNO. We need comparative effectiveness trials and trials of new emerging biologics that may be very, very effective as interventions for CNO and SAPHO patients. It's extremely concerning that there are huge disparities in care and the availability of tools for physicians to prescribe depending on where you live, insurance coverage, other factors. I think it's really a huge problem. So participating in the OMRAC group, which I think is what Melissa asked me to talk about, has been a complete privilege as a parent with a child with this disease, and incredibly meaningful. I value this work absolutely tremendously, as I know all the patients and caregivers who are part of our community and are involved in this project. Melissa is a truly amazing physician and an even more wonderful human being. I am supremely grateful for you and your awesome work for our kids and adult patients with CNO, SAPHO. And I just want to take this opportunity to thank you and Christian and Marinka and Phil and Bev and everyone involved in the CNO work group. Your work on this project is hugely important and is appreciated perhaps more than you could ever know. I don't know that there are any industry representatives out there, but if they were, I'd be exhorting them. We're ready to partner with you to support these urgently needed trials of existing and new drugs to combat this insidious autoinflammatory disease. That's me done.
Thank you, Alex, because you have been a tremendous help and asset to our group with everything that we've been doing, not just the OMRAC project. All right, so I'm just going to give a quick, brief review again for those who aren't too familiar. You heard some of this already from Christian, but what is CNO? So it's an autoinflammatory bone disorder, commonly presents with bone pain, lab findings are not very helpful for us sometimes. So you can see normal labs, you can see mildly elevated inflammatory markers most commonly. On imaging in later stages, you can see lytic lesions and sclerotic lesions on radiographs, x-rays. And on on MRI, you'll see earlier signs, hyperintensity in the bone marrow. And so MRI has become a very useful tool for us with monitoring our kids. So SAPHO, as we also mentioned, whether or not this is the same disease in a different population, two different ends of the spectrum, I'll leave that for other people to debate. But it also has the bone inflammation, the osteitis, but has other more prominent extra osseous manifestations, the acne, pustulosis as well. This more commonly presents in the adults, but can also present in children, although I don't commonly see it as well either. I think I've had one maybe. But CNO does more commonly present in kids. The peak age of onset is between 7 and 12 years, but it can extend into adulthood as well too. So there is that overlap, which is why when we first formed as an OMRAC group, we had decided that we're including both disease entities and that we're also making this pediatric and adult. So we haven't separated whether or not we're doing just peds only or adult only. So you'll see later on when we do our breakout session that why there are some other disease manifestations such as skin, gut, and joints as well too that are on the candidate domain list, because there is a spectrum to this disease and there are other extra osseous manifestations that can happen. Most commonly it's skin. So the first line therapy is typically NSAIDs. However, a good percentage of patients don't respond to NSAIDs alone and need to move on to second line therapy. And most commonly that involves TNF inhibitors and bisphosphonates. DMARDs are mentioned on there. They're not as effective, but they're still used. Sometimes it's for insurance, but sometimes they work as well too. And SAPHO as well, similar kind of algorithm for treatment use, although they also will sometimes use antibiotics, I think. But again, NSAIDs are only partially effective for them. So we have been seeing, I think, an increasing number of patients who may not have been responding to TNF inhibitors and bisphosphonates for various reasons, whether or not for treatment efficacy or for development of side effects from those medications. So TNF inhibitors can induce psoriasis, a paradoxical psoriasis. So then it leads us to think about, well, what other options are out there? And as you had seen from Christian when he talked about the other mechanisms, people are exploring IL-17, IL-12/23 inhibitors as well too, and maybe JAK inhibitors. So yeah, we do not have a core domain set yet for CNO and SAPHO. It has never been developed, but there have been outcome measures that have been used in the literature, not many. There's the PED CNO score, the consensus treatment plan, criteria for treatment failure that was developed by the CARA group. And then I had also found another article that had mentioned about a SAPHO osteitis and skin score. There wasn't a lot of detail in about it, but the other two mostly just encompass pain, imaging findings, and inflammatory markers. So things that are, probably missing from those criteria that are still pretty, important for monitoring the outcomes of patients with these diseases. Additionally, there really wasn't a lot of input from other stakeholders. They're primarily developed by physician groups. So that's why we're here. All right, so now I'm going to review what we've done so far, but if there's any questions, feel free to raise your hand and we can go around and, do the mic. We can keep it informal. All right, so as I mentioned before, we are doing pediatric and adult with CNO and SAPHO. We're taking everybody into this outcome measurement set. This is our PICO. So, our outcome is to develop this core domain set for all clinical trials of these patients. We are in the generating phase. I think we're coming close to almost finishing this. We've done our scoping review, and then we've done our qualitative methodology, which is we held focus groups and online discussion boards. And I'm going to go into more detail about that. This is very small if you can't really read it, just to kind of show you an outline of what we've done for our scoping review. And we had about 3,000 articles to begin with. After reviewing the abstracts, we excluded a good number of those, about 2,400, leaving us with full text about 570. And then had a great small group within the working group to kind of go through all those full text and include 260 into our scoping review. And from there, I didn't actually put this in there. You guys saw my lightning talk. We got over 200 outcome candidate domains from the scoping review, which we will be narrowing down. Our virtual focus groups, we held those in February of last year, and we had 21 participants. We had 2 parent groups. We had 1 pediatric patient group. We had 1 adult patient group, and then we had we called a provider group, but that encompassed an industry representative, 2 pediatric rheumatologists, 2 adult rheumatologists, and a physical therapist. They were from all over almost. I know we had that big discussion about trying to include continents that are not really representatives, and unfortunately we didn't because we held these in English. But we had primarily North America, 5 from Europe, and then 1 from Asia. We, because Australia and New Zealand, one of our co-leaders is from there, they're a big part of our group. We didn't want to leave them out, so we were able to hold online discussion boards with them. This was led by a qualitative methodologist, Susan Thornhill, who really did almost the whole session for us, thank God, because the time zone difference was not feasible for the rest of us, but she was great. We had 4 focus groups, encompassed a total of 20 additional patients. We had a parent group, we had an adult group, and it says adults with SAPHO because all of them identified as having SAPHO. None of them identified as having CNO. And similarly, the teen, and then we had a teen group and then a young adult group. And those patients primarily identified with CNO as well too. So that's why we didn't specifically exclude only adults with SAPHO and teens with CNO. And in case you're just interested, this is kind of where they stood at the moment that they were doing their online discussion board. It was nice to see that most of the teens and young adults were actually kind of inactive when they were doing the discussion boards with us. They still gave us a ton of information though. And the adults, unfortunately, were all very active and not doing too well. They did a great job with the discussion boards, but I know that some of them had actually struggled to kind of get on and answer some of the questions. But we were very happy that we were able to include them. So from those 3 sources, we had, from our scoping review, 220 candidate domain items, from the focus group, 79, online discussion boards, 28, totaling 327, giving us a headache. And so we were able to, with the help of these wonderful individuals I have named up here, kind of divided and conquered each one and essentially narrowed down the list. And that's what we're going to keep on doing today. So we were able to narrow down the list quite substantially, removing duplicates, removing things that weren't relevant, kind of condensing things to similar themes, and able to come up with, actually, it's not even 114 yet. It is 98. So we're going to have a list of 98 that we're going to go through today. So if you think about where we came from, 98 is pretty good. That's what we will be doing today. And then the goal will be next steps. Actually, before this, we'll be working on our definitions, and then we'll be doing our Delphi survey. But I put this up there in case anybody's never actually done a Delphi survey to kind of understand what it looks like. So when you actually participate in the Delphi survey, you're going to kind of rank these items on a scale of 1 to 9 as to what you feel would be, critically important and to conclude in our core domain set versus what could be optional or what could be more kind of researchy. This is a QR code. I'm going to show this multiple times later on, but if you want to just participate in the Delphi surveys and just kind of gathering everyone's information so you can, it's just a QR code to a red cap that asks for your name and email. And I have it at the end too, in case you want to think about it. All right, So I think we're doing pretty good on time. Yes, all right. So now we're gonna get into our breakout groups. So what I'd like to do is we probably can do 2 breakout groups, and I will split up us and split up the patient research partners as well too. Okay, so we'll figure it out in a second. So because it's 1 a.m., 2 a.m. in England, we will not have a virtual breakout group, but I can give you guys the link in the chat for the virtual participants, and feel free, you can download it and do it on your own and email it back to me. That's totally fine. And then the rest of us will do it in this live session now. I don't know. Is anything in the chat? No. Okay. It's very late. Okay, so we're going to review the list. I have paper copies. We're going to kind of go old school with this. And the idea is to condense and narrow this down to what ideally would be a more feasible number. The goal is 35 to 40, but I don't know if we can narrow it down to 60, that would be nice too. And so when we get into our breakout groups, I want you, if you need to, introduce yourself again. I wasn't sure if we were going to be able to introduce ourselves, so you don't necessarily need to. Yeah.
I'm not a CNO expert, then
It's totally fine.
I'm worried that I'm going to sort of skew the data.
No,
That's fine.
you can
okay.
totally participate. That is totally fine. We will have a content expert in the group, which will be one of us 4, or actually there'll be 2 content experts. And you could totally ask any questions that you're not unsure of. We'll need one of us to be a reporter and just kind of hand in the main copy to me. So we'll just, since we're doing 2 groups, we'll just have 2 main copies, which would be nice. That's easier for me to look at. Okay, so let me hand some of this stuff out so you guys get it. Oh, thank you. Thank you, Beth. Okay. So, yeah, so I don't want to do, you guys want to, we'll do this group, that group, and then we'll split us up. Yeah, okay. And then I'm going to give you guys instructions. Yeah, Bev, they need some more over here. Yeah, they moved. Perfect. You can go to sleep. Yeah, that would be fine. Yeah. Yes, I will. And I can send it to Maricela too. Okay. Awesome. Okay. So if I can get everyone's attention again, I'll kind of give you a little bit more instruction. I feel like you might need it. So there are not, like I said, there are 98 items. How I gave you guys the Excel spreadsheet, there might be a little bit more additional information that you don't really need. You're going to be focusing on that first column, the target domains, because the target domains are what goes into your Delphi survey. But if you wanted to, know other things about the broad domain, the core area where it's coming from, the sources where it's coming from, I just kind of left that all there for your information as well too. So you can kind of see, did it come from the focus groups, the scoping review, the slides from the online discussion boards, did it come from all of them? So what we're going to be doing, if anybody attended the binning and winnowing session, we're really going to be kind of doing that. And then kind of ultimately giving your decision about whether or not that item should be included in our Delphi survey. So binning. If you go through the list, you see things that are like items, like domains, similar themes, similar concepts of interest, and you feel like there's another name that encompasses them, or they're just kind of the same and one name fits better, then just eliminate the other one, use the one. And then winnowing. So if you weren't familiar with winnowing, so there might be items on there that either are redundant, a little too narrow, too broad, as in it feels like it's multifactorial, could explain a couple different domains, not just the domain it's fitting in. Is it unclear? Does it make any sense? And do you think it can stand alone on its own? But if it doesn't fit any of that stuff, feel free to, we're just gonna you eliminate it then at that point. You don't think that it's relevant at all. So that would then fall into your definitely exclude. So as you go through this list, feel free to talk, and see, has this already been named? Is this the same thing as something else? Do we exclude it? Do we include it? And I did give you an option for somewhere in the middle for a maybe include if you can't commit to it. So yeah.
I just wanted to clarify the purpose of this is to identify domains for which we will develop instruments which will be used in clinical trials to document efficacy of a therapeutic. Is that correct?
Absolutely correct. Yes, as if you had read it from the Elmeract handbook yourself. That is totally correct. And then the last caveat I'll give you, I mean, I want you all to agree on it together. So one person's going to submit one thing to me. So I want a consensus as part of Elmeract. You're all going to agree on it together. If one of you feels very strongly that it should be included, but the rest of you don't, just so you know how Delphi surveys work, there is an option to include an other item yourself. So when you participate in our Delphi surveys, you can throw it back in. Okay. We actually have some definitions for it too. Oh, that's it, independent. I think it's independent. Yeah. Activities of daily living and independent activities of daily living. Sorry. And I will take the master copy. You feel free if you want to keep your own, that's totally fine. I'll take my copy and the master copy. Okay, thanks. So I hope that at least our table seemed productive. You guys were talking a lot too, so hope you guys were also productive. Does anybody have any comments or questions or want to talk about what we all just went through? Or maybe I might come over to Marinka. Any summarizations from your small group breakout?
No, I think we really were able to like combine and make bins. So I think that really helped, that some things we just put on a bin as like economic impact, and then we can later look, or physical assessment, and then we put skin and arthritis and everything underneath it, so that it at least takes a lot out of it. So I think we were really effective actually, and everybody was really engaged.
10. Oh my God. Okay. Any discussion comments from our group you want to add or anything? I think we had a very similar experience. We were a lot of things that we felt like we could bin and then could, kind of delete because they were a little redundant. So I don't know if we got down to 10 or 15 though, but yeah. Yeah, that's fine. Any areas that was like particularly challenging or you struggled with? I will say we struggled with the mental health section and the pain section.
So yeah, so there were some like lively discussions about those items, yeah. And function also, like, what is like function in daily life, and should that be separate from activity function or normal function? So those were discussions we had.
So it was disease, because got disease flare, and then realized disease damage wasn't there, and that could be important. So I thought it was quite interesting because it was like.
That's okay. What did you guys add?
Oh, it was more like the pain quality, that in the future we should measure or record certain pain qualities we tend to ignore nowadays. Like dysesthesia, paresthesia, stuff like that.
We felt that there might be, although depression and anxiety are sometimes measured in clinical trials, and and I can remember one of the early trials with etanercept in psoriatic arthritis, there was a demonstration of improvement of depression. We thought that this was kind of a special domain for kids to pay more attention to, and didn't want to lose that under the rubric of just health-related quality of life, which it's often tempting to shove everything in there, but that's a very important one, we thought. And yeah. Right. And the other thing that we don't have in adults is as much role for parent caregivers. So there was a thought that we should, at least in the research circle, of the onion, have parent and caregiver burden evaluated by some kind of instrument.
Great. Anything else? Any other last minute comments? With that, then, oh, you all did an excellent job. So thank you everyone for coming today. I want to thank my co-chairs who are here today, Christian and Phil, and then of course Dan and Jonathan, who couldn't be here today. Bev, thank you so much. I bug you all the time. Alex, thank you as well. And Marinka, thank you for being a wonderful work group member. You really are part of our steering committee. And if you guys want to participate in our Delphi survey, don't forget to capture that QR code. It's also on my poster tomorrow. So, and I'll pop it up in the daily SIG session tomorrow as well too. All right. Thank you.